Hello, good morning, afternoon, evening, wherever you are in the world. This is the organized webinar on behalf of World Gastroenterology Organization. I welcome you all. The webinar will be focused on identification, diagnosis of drug and herb-induced liver injury. We've got a panel of 4 excellent speakers. These have been in the front of some of the step changes that will come into this field in the next few years. They're the authors of some of the leading articles in this area. I am Guru Aithal. I'm from University of Nottingham. I would be inviting Professor Ayako Suzuki from Durham Veteran Affairs Healthcare System, USA, Nelia Hernandez from Hospital de Clinicians, Montevideo, Uruguay, Paul Skip Hayashi from Division of Hepatology and Nutrition, FDA, and Paul Watkins from University of North Carolina, Al Halman School of Pharmacy and Institute of Drug Safety Sciences. Speakers will talk about the topics which are as advertised. And first 3 are video presentations, followed by Paul Watkins will be speaking on live. Please type in your questions in the Q&A section of the site. And we will come back for the panel discussion at the end of the presentations. So I'll start off with the presentation from Professor Ayako Suzuki on algorithms to identify drug-induced liver injury, followed by Nelia Hernandez talking on causality assessment of herb and dietary supplements, Hayashi talking on RUCAM to RECAM, followed by genetic risk score for diagnosis. I'll pass it on to WHO Secretariat, who will run the videos and facilitate a presentation. I'll come back to join the panel.
Hello, I'm Dr. Suzuki from Duke University Durham VA Medical Center. The title of my talk is Algorithm to Identify Drug-Induced Liver Injury: How to Utilize EHL Data to Improve DILI Assessment and Diagnosis. Here is my disclosure. I have no conflict of interest. Here is outline. After brief background, I will present methodologies step by step, how we utilize structured EHL data to identify drug-associated acute liver injury to study real-world DILI. I will use amoxicillin carbonate as an example and share some of the result. Lastly, I will discuss how EHL DILI research can be utilized to complement our knowledge to improve our future DILI diagnosis. DILI is one of the most difficult diagnoses in hepatology, since no pathognomonic features, biomarkers, or diagnostic criteria. DILI case assessment involves multiple components and determined likelihood of DILI. Key diagnostic components include chronological relationship, time to event, exclusion of other etiologies, and response to drug discontinuation and rechange if clinically indicated. Several causal assessment tools are available to standardize the assessment, which will be covered later in this session. I believe current DILI case assessment can be improved if we have more information, such as drug-specific information about degree of hepatotoxic potential, measured by incidence and severity, drug-specific signature pattern, host risk factors. Adding such information will augment our ability to more confidently determine DILI likelihood, and if it is DILI, which drug is culprit. Both drug and host determine DILI risks. We learned which drug properties can potentially cause human DILI. but we have significant knowledge gaps at the host side. We also don't have an overview of real-world DILI yet. A previous study conducted a proactive real-time monitoring to identify DILI cases and compare the number of identified cases with standard referral-based case identification. Based on their data, we are likely experiencing only a portion of DILI cases through referral, 1 in 12. So we need new approach to study real-world DILI and learn about host risk factor. We used VA EHR system. This is one of the largest unified EHR system in the United States, managing data from over 8 million veterans nationwide. The EHR dataset contains encounter note and diagnosis, pharmacy record, and laboratory data, and so forth. Such data can be utilized to define drug-specific exposure cohort, including cases under control. The EHR system also provides enriched longitudinal data, providing pre-exposure liver enzyme and medical history, and follow-up data after the event. First, we defined the exposure period by drug initiation date and end date. And based on the patient status at the time of drug initiation, we classified them into outpatient and inpatient exposure. To define drug initiation date, we used drug dispensing or shipping date, whichever was later. Drug end date was set as drug initiation date plus a number of dispensed days for a single prescription. For recurring prescriptions, exposure period were concatenated, applying several rules to pharmacy record. Details are described in the publication. Using the algorithm, we identified 2.6 million amoxicillin clavulanate exposure over 15 years in 1.4 million unique patients. Yearly exposure was 22 per 1,000 patients. During the 15 years, 63% had a single exposure, while 27% had 2 to 3 exposures. Exposures per patient ranged from 1 to 146 exposures. The number of yearly exposure differed by age and sex. Age group 55 to 64 was associated with highest exposures, regardless of sex, twice of the average exposures. Overall, women had slightly higher exposures compared to men only among younger subjects. From 2.6 million exposures, we selected the 1.4 million first exposures. Then we collected relevant ICD codes and laboratory data during 3 years prior to the exposure and identified the existing liver diseases and divided the cohort into liver healthy population and population with existing liver disease. About 70% did not have any existing liver disease. The subcohorts were further divided into inpatient versus outpatient exposure. Overall, 86% were outpatient exposure. We then defined high-risk period following drug exposures. The high-risk period was defined as either drug initiation to 30 days after drug discontinuation or the first 90 days of drug exposure if treatment exceeds 60 days. During the high-risk time period, we identified acute liver injury using liver chemistry data. ALT higher than 5 times upper limit normal or representative baseline value, or ALP higher than 2 times upper limit normal or representative baseline value. Overall, 85% and 32% in the cohort had at least one liver chemistry data during baseline and high-risk period, respectively. As expected, the rate of data availability differed based on the presence or absence of existing liver condition and patient status. So missing data in EHL system is not random, influenced by various factors, and this should be in our mind when we interpret data. Subjects who did not have liver chemistries during a high-risk time period were considered to have not developed clinically significant acute liver injury and treated as untreated control. Here is the incidence of overall acute liver injury following amoxicillin clavionate exposure. Incidence rate was 0.45%, captured within the high-risk time period following exposure. The rate was significantly different among the subcohort by liver conditions and patient status. Population with existing liver condition increased incidence more than threefold, regardless of patient status, and independently, inpatient status also increased incidence more than fourfold, regardless of pre-existing liver condition. Next, we applied different exclusion algorithms using relevant ICD code and lab data to identify competing etiologies for acute liver enzyme elevation. We collected relevant ICD code and lab data between -7 days to +90 days from the event date. These algorithms were developed and refined based on our case review on 18% of randomly selected cases identified using our previously developed framework. The algorithm covers all the disease conditions we generally consider in our clinical assessment of potential DILI cases, including biliary pancreatic disorder, acute viral hepatitis, alcoholic hepatitis, as well as non-hepatic causes of liver enzyme elevation. Due to the time constraint, please refer to the publication for detail. Among acute liver injury cases, 65% had at least one of other etiologies explaining liver enzyme elevation. This population varied among the subcohort from 60% in liver healthy outpatient to 7% among inpatient with pre-existing liver condition. This proportion likely differs based on which cohort we target, community versus academic centers, and general patient population versus specialty population, because the extensiveness of clinical workups may differ. Among the competing etiologies, top etiologies excluded were biliary pancreatic disorder 30%, heart failure 10%, systemic inflammation or shock 9%, new hep C, hep B infection, new diagnosis autoimmune hepatitis, and alcoholic hepatitis were identified in less than 2%. This slide summarized the entire framework to identify acute liver injury following amoxicillin clavionate exposure, unexplained by other diagnosis of liver enzyme elevations, which is considered drug-associated acute liver injury. Among 1.4 million amoxicillin clavionate exposures, incidence of acute liver enzyme elevation was 0.45%. Of them, 2 in 3 had other etiologies. The incidence rate of drug-associated acute liver injury was 0.16% and significantly differ among the subcohort. Pre-existing liver condition and inpatient status were associated with significantly higher incidence of drug-associated acute liver injury. Briefly, using this cohort, we were able to identify several risk factors. After adjusting for other factors, older age, male sex, American Indian or Alaskan Native, existing liver condition, and inpatient status were associated with a higher risk of amoxicillin clavionate-associated acute liver injury. 74% showed cholestatic injury. Cholestatic injury was also associated with older age, Black race, existing liver conditions, and inpatient status. Incidence of high-low case was 0.003%, 14% among hepatocellular injury, and higher risk of high-low cases were observed after age 45 years. Lastly, I summarize strengths and limitations of EHLD identification for research purposes. Strengths include drug-specific exposure cohort for studying incidence and risk factors, including co-medication and existing disease condition. Since identification does not count on physician's recognition, this approach could provide an overview of real-world DILI. Combining other resources, this approach allows us to address drug-host interplay and gene-environmental interaction in a DILI risk. Limitations include some caveats inherent to real-world EHL data, non-randomness of missing information, data bias introduced by clinical and administrative decision. Lack of sufficient data for definite diagnosis resulting in a large number of possible yet indeterminate cases. This approach may not be suitable for studying complex cases. Also, acute liver injury associated with drug-drug interaction or other drugs may be contained in this cohort. In summary, large EHR dataset can be utilized to define drug-specific exposure cohort, including both cases and control, to learn about real-world DILI. Acute liver injury following a specific drug exposure, unexplained by other diagnosis, can be used as a new entity to reduce incidence, phenotype, and outcome of drug-specific DILI event. Inclusive, systematic approach to identify potential DILI cases could provide an overview of real-world DILI, complementing existing approach in DILI research. This approach can augment our knowledge of clinical risk determinant, drug-drug host interaction, which aid in future DILI assessment and diagnosis. Here is my acknowledgement. Thank you for your attention.
Good morning or good afternoon to everyone. Being part of this webinar is a great honor, and I am very thankful to the WGO and Dr. Aithal for this privilege, and of course to my colleagues. My topic is causality assessment of herbal and dietary supplement induces liver injury. A very interesting topic, but really a difficult one. Let's start with the concept of HDS, which refer to all products previously named as traditional, alternative, or complementary, and it involves many compounds and ingredients. As you can see here, we have herbs, which include herbal medicine, traditional Chinese medicine, and the ancestral Ayurvedic medicine. The dietary supplements, like vitamins, proteins, enzymes, amino acids, and the multi-ingredient nutritional supplement with only rare description of their concentration and source. And in this group, it's also included the anabolic steroid, which really do not belong to this group, and they should probably be recategorized, maybe as hormonal components. Liver toxicity related to the consumption of herbs is a growing health concern that is clearly being observed in all the DILI registry, as you can see in this slide. Even more, herbal medicine toxicity is the second most frequent cause of DILI in the United States, as well as in Latin America, as we will show soon during our next Congress. It also happened in China, where HDS liver toxicity is in the top 1, as you can see in this graphic. Outstandingly, as I will speak shortly, liver failure linked to herbs have shown a purer prognosis than the conventional drugs. Which are the reasons that explain this increasing use? Beyond the cultural issue, as happens in many countries of Asia, there are many reasons connected with the higher consumption of herbals, starting with a historical security reputation, a lack of specific and rigorous regulatory control, self-diagnosis and self-medication with a very easy access, besides the frustration with the lack of success of traditional medicine, like happens in obesity. In this slide, we can see that herbal use for weight control is one of the most common cause of liver toxicity. We should be aware of the typical clinical presentation of severe DILI, characterized by a younger people with a female predominance and an acute hepatocellular injury with markedly elevated aminotransferases and bilirubin. Severe DILI is prone to a non-intentional rechallenge and a greater risk of death or need for liver transplant. We have a different phenotype associated to jaundice and renal failure that has been linked to anabolic steroid, and stanozolol is the best example of that. Diagnosing HDS hepatotoxicity requires the same stepwise approach when conventional DILI is suspected. Herbal injury can present clinically and pathologically with all liver disease phenotypes, including hepatitis, cholestasis, and vascular disease. We need to identify information in its use, clinical manifestation, laboratory, imaging, histology when we have, and a careful exclusion of other etiologies. But awareness of the potential of HDS to cause liver injury is probably the paramount for diagnosis. HDS DILI diagnosis is extremely challenging, probably more challenging than DILI, and it may have many explanations. HDS may contain multiple and even undeclared ingredients that may be the real culprit of DILI very often. HDS are often used concomitantly with conventional medicine, and some products contain both compounds in a legal or illegal way. Indeed, several times, neither the composition nor the active ingredient are identified, and herbal terminology varies across the different countries, limiting the identification of the active ingredient and its hepatotoxicity potential. At last but not least, most patients do not report HDS use, which is more remarkable in anabolic steroid use. In this paper, published some years ago, the author collected 40 cases from 22 articles and demonstrated the presence of one or more adulterants of Chinese herbals with conventional drugs like indomethacin, diclofenac, phenytoin, and acetaminophen. They also found that 24 and 7% from Taiwan and US respectively contained pharmacological agent, and about half of the individuals taking herbal medicines do not tell the physician about it. More recently, Dr. Navarro and colleagues have demonstrated the high prevalence of mislabeled products and the several compounds with a great potential of DILI that could be hidden behind an HDS. 272 samples from cases with liver injury because of herbs from DILI network were analyzed. They found that 50% were mislabeled and 55 contained compounds that were not listed as anabolic steroids, tamoxifen, and diclofenac. All that I mentioned about the growing incidence and the highly challenging diagnosis are only part of the reason that justify both the need and the difficulties for getting an efficacy method for causality assessment in HDS liver injury. So, let's discuss which are the available tools that we have to evaluate causality in DILI. We have algorithm scale and by one side and expert opinion by the other. In the first group, we have RUCAM, RECAM, or the evidence chain method, and in the second group we have the structured or non-structured expert opinion. The RUCAM scale is recommended by the European Association and is widely used for DILI causality assessment as it is liver specific and validated for hepatotoxicity. It's very useful in the assessment of DILI cases in the post-marketing, and it evaluates 7 key elements which are scored, and some provide the final diagnosis: definitive, probable, possible, unlikely, or excluded. But when we face a HILI case, this scale is limited because warning labels are a rare abyss, and the frequent polypharmacy of these supplements are a very important limitation that may reduce the final score. The RUCAM scale has recently been updated and computerized and moved to RECAM, revised electronic version of causality assessment method for DILI diagnosis. The author removed 2 criteria: risk factor and competing medication, and the drug-specific risk was anchored to liver tox likelihood scale. The main advantage of this revised scale is a better agreement with expert opinion and a better sensitivity to detect extreme diagnostic categories. Even if we use them, it is crucial to remember that none, RUCAM or RECAM, was explicitly created for HDS toxicity. The structured expert opinion process, COP, is recommended by the American College of Gastroenterology. This is a powerful tool to evaluate causality, especially for the new DILI cases, and is based on a consensus of experts. In general practice, it is usually limited by the scarcity experts and the need for an additional independent review when the agreement has yet to be reached. Another disadvantage is the possibility of considering non-objective factors in the diagnosis process. 5 years ago, China Association of Chinese Medicine Guideline presented a workflow strategy specially designed for DILI with 9 criteria. In the first step, they recommend to use RUCAM scale, and after apply it, those cases with score 3 or more, possible or more, were considered as suspected cases. After that, they use specific methodology to exclude combinational use of synthetic drugs and confirm the clinical diagnosis. The last step is the detection of characteristic biomarkers associated to DILI, and then they confirm the case. The APASAL guidelines support this HDS causality assessment methodology, which has 2 essential advantages. It is the only causality assessment method created to evaluate causality in DILI, and it considers all the specific and confounding factors that could appear in the adjudication process of DILI. As a disadvantage, we must consider that it requires not widespread or easy access technology. And my question is it workable for the rest of the world? In summary, HDS-induced liver injury has increased proportionally to the global growth in HDS consumption. HDS liver toxicity still poses several clinical and research challenges, and the reliable identification of offending ingredient is a major one. A validated causality assessment method of HDS hepatotoxicity is urgently needed. The one proposed in China still awaits validation. The evidence chain method causality identification is the only design for DILI, but it does not seem to be easy to apply outside Asia. Thank you very much for your attention.
Thank you for inviting me to speak at this webinar about diagnostic tools for DILI, and specifically RUCAM to RECAM. I have no disclosures other than to say that this is just me talking and not the US FDA. So first we're going to review the RUCAM a bit. The RUCAM was first published in 1993, so it's been 30 years. And no other clinical diagnostic tool for DILI has been able to replace it. So it has done fairly well, but it has some limitations. And I'll point them out as I quickly go through the RUCAM. There are 7 criteria for RUCAM, and the first 3 are shown here. But the first step is actually you have to decide whether you have a hepatocellular or cholestatic mixed injury. And this is based on the R value, which is the ratio of the ALT to alkaline phosphatase, each normalized before its upper limit of normal. An R value of less than 5 is considered cholestatic or mixed, and greater than 5 hepatocellular. Once you've done that, then you know which column you're to be in. The first criteria is latency, arguably the most important. So, for example, if you have a DILI injury, liver injury, that occurs 5 to 90 days from the time you start the drug, you'll get 2 points. If it's less than 5 or greater than 90 days, you get only 1 point, and so on. There's also time from drug stop. So if you stop the drug and the injury happens within 15 days, you get a point. The RUCAM says you should score either one, but not both, and it's left to the user to decide. Now, D-challenge is how quickly the liver enzymes improve after you stop the drug. For example, in a hepatocellular injury, if you have a greater than a 50% drop in the peak ALT in 8 days, you get the maximum points of 3, and so on. The risk factors criteria, which are alcohol, pregnancy, and age, are shown. Arguably, this is the criteria that is the most wobbly. A lot of people in the field were not clear whether these factors really contributed much to the RUCAM diagnostic score. The other thing I'll point out before I move on to the next criteria is that for the most part, these criteria are fairly objective. Except for ethanol or alcohol, this one is left to the user to decide how much alcohol, how recent, etc. But otherwise, these are fairly objective criteria. You just have to enter in the data correctly. Now, the next 4 criteria are shown, and you pick up some more subjectivity as we move through these criteria. For example, concurrent agents. This is where when you have drug A that you're trying to decide is DILI, but there's also drug B that was taken at the same time. So if drug B is a known hepatotoxin with suggestive timing, then you'll penalize drug A by 2 points. Makes sense, but the problem here is that the definition of hepatotoxin and suggestive timing is not clear. It could be different from one user to the other. Other diagnoses and competing causes. Here, group 1 is viral hepatitis, alcohol, the more common things to cause liver injury, and group 2 loops in some less common ones like CMV and EBV. And if you, in your judgment, ruled both of those out, you'll get 2 points, and so on. The DILI risk is how often that particular drug causes drug-induced liver injury, and this is based on the product label and what's published in the literature. And here, this is rather subjective because a product label may just say, well, the liver enzymes went up this percentage of the time in the clinical trial. Other labels will have a box warning or a warning and precaution. So should they all get 2 points, or maybe just the box warning and warning precautions? That's left to the user to decide. And then published literature, by the same token, is one brief letter of a DILI that's not very well documented compared to a full publication of 20 cases of DILI. Should they both get 1 point? And then readministration of drug or rechallenge is pretty self-explanatory. The only thing I'll say there is it doesn't happen that often. I think in the DILI it happens less than 5% of the time that we have a rechallenge, positive or negative. Now, as I have alluded to, there are some what we call reliability issues. Reliability is not validity or accuracy. It's all about whether you are getting the same score each time you score. And here we just show the intra-rate reliability data from the DILI who did RUCAM scores on their cases and then waited a bit, and the same reviewer looked at the same case and scored it again. And as you can see, there was some variation that was either lower or higher in this study. The reliability coefficient was only 0.54. The inter-rater reliability was even a bit worse, with the coefficient down in the 0.4 range. So this is a problem for both clinically as well as in research in terms of identifying DILI cases. So based on those shortcomings and issues, the DILI and the Spanish registry groups got together and embarked on a project to see if we could revise the RUCAM and create what's called a revised electronic version of RUCAM, or RECAM. This is just a snapshot of the study that was done over a few years. The updates were based on case data wherever we had it, evidence-based in other words, expert opinion, and iterative testing on groups of 50 to 100 cases from each registry, until we came up with a final model. And here is a snapshot of, by box plot, how it compared to expert opinion in the two registries. And I'll show this slide again in a minute. So sort of the bottom line on top about what happened to the RUCAM as the RECAM was developed. So the RUCAM criteria on the left and the RECAM changes on the right. Right off the bat, you'll see that there are 7 RUCAM criteria, but now only 5 in what we call domains. And even the 5th domain is considered additional data or optional. The latency from start and stop is now both will be scored. As you remember, RUCAM, it was one or the other. The range of scores was widened, and the latency from drug stop only penalizes in domain 1. Domain 2, which is de-challenge, which is where the RUCAM differs the most along cholestatic, mixed, and hepatocellular. Both in the DILI and the Spanish registry, it didn't matter. So this step of discerning between these types of injuries was eliminated. Risk factors, age, alcohol, and pregnancies, these were eliminated. As we suspected, they did not help diagnostically in the RECAM. Competing medications was also eliminated. The group felt that to give justice to another drug that you were actually thinking might have caused a DILI, that drug probably deserves a full accounting and a full score on its own. So for now, the RECAM is a single drug, one at a time, independently scored for each drug that you suspect. Competing diagnoses were updated, expanded, and instructions tightened. The DILI risk score, which was based, DILI risk, which was based on labeling and published literature, somewhat subjective interpretation of those, was now anchored on the liver tox likelihood scores, and I'll show that in a minute. Rechallenge, as I said, doesn't happen that often, so it was moved to domain 5 as additional data. So this is the performance of RECAM, RUCAM by expert opinion versus expert opinion. RECAM on the left, RUCAM on the right. Same 194 cases from both the DILI and the Spanish registry. The cases were categorized based on expert opinion in these four groups here. As you can see, there's a couple things. The scale or the range of scores on the RECAM is wider than on the RUCAM. This was done by design. We felt that the RUCAM scores were a little too tight and would have trouble discerning the expert opinion DILI cases. And as you can see, this is we were correct in that the RECAM seems to do a better job at discerning the different categories with widening of the scores. Now, truth be told, when you look at things like the Spearman's Row or areas on the curve between probable and higher and possible and lower, the AUCs are actually the same or very similar between the RECAM and the RUCAM. This has to do with these overlaps, these whiskers where there's a significant amount of overlap. So again, RUCAM and RECAM are neither one are perfect, but at least its data on the left suggests that RECAM may be a little bit better at discerning cases based on the expert opinion scores. So let me show you a few things. First of all, domain 1, latency. This is onset after drug start, DILI or injury onset after drug stop. Both are scored in the RECAM. One or the other is scored in the RUCAM. And here again, you see this widening of the range of scores for both. And then I want to point out this -6 with the gray box. You'll see these as we go through the slides. What these are, they are warnings and heavy penalties when you've put in data that is inconsistent with DILI. For example, here, the DILI onset is occurring before the drug was taken or on the same day the drug started. And we would consider that quite unlikely to be DILI. And the computer will tell you that maybe you should just stop while you're behind, give a total score of -6, and say this is unlikely DILI. Show you domain 3. This is the one, remember, RUCAM uses label and literature. The RECAM uses liver tox scores. So this is done by the computer. You enter the drug, and the computer will go find the liver tox score, A and B meaning this many cases in the literature, C, D, and E primed, E and X, and so forth, and you get these many points, 3, 1, and 0. And here's some examples of the liver tox likelihood scores for some drugs you may be familiar with. So again, you enter the drug, the computer will go find the likelihood score and enter the points for you. Domain 4 was the most difficult to do, obviously. It's complicated, ruling out competing causes. And I'm just going to show you the autoimmune hepatitis one because it gives you a sense of what the computer is doing behind the screen. So for example, if you enter, you have a drug, minocycline or nitrofurantoin, you will only see the menu highlighted in red right now. You will not see this menu on top. This is the one you'll see. And if you have positive markers for any of these, you will get a point. Why? Because those are often positive in DILI due to these two drugs. Now, on the other hand, if you don't have one of those two drugs, then you'll see this menu on top. And here, if you have one of those markers positive, you actually lose a point. Why? Because autoimmune hepatitis is now competing. Moreover, if you have one of these markers along with a liver biopsy with typical features of AIH, you're going to get a warning again and a heavy penalty of -6. These are the criteria of probable AIH in the AIH scoring system by the AIH scoring group, interest group. Similar types of things are being done for alcoholic hepatitis. For example, if the ALT to AST ratio is inconsistent with alcoholic hepatitis, you won't see much of a drop-down menu. It'll be a pass-through. You only get one choice saying alcoholic hepatitis not likely. Same thing with sepsis. If it's an R value greater than 5, hepatocellular injury, you'll get a one-line menu. It just says cholestasis sepsis not likely to be causal. So what does this look like on the site? Now, we've had some problems with the site because of a security issue and virus issues, but it's been fixed and it's back up and online. So what you'll see is drop-down menus where you pick dates, drug start, stop, DILI onset, etc. And then the computer will give you the scores for those domains. You enter your labs, upper limit of normals. You can enter the drug, type in some letters, and it'll pop up the menu choice. This one's isoniazid. And then domain 4 will have drop-down menus. For example, this is Hep A. Either you're missing the test, in which case you'll be penalized 3 points, or it's negative, in which case no penalty, or it's positive, and that's one of those, again, -6 is saying, hey, you might have Hep A going on here. This is less likely to be DILI. So that is a quick overview. I was only given like 15 minutes, but I did want to end with a couple things. This is a work in progress. This is RECAM version 1.0, and we want to keep moving along and try and keep this tool developing. There are issues that we want to address. For example, reliability studies, which the DILI is now undertaking. Long latency drugs, neither the RUCAM nor the RECAM score those very well. The checkpoint inhibitors, for example, that come on several months after start, you're not going to get any points in that when you should actually. Multiple drug cases, I kind of covered this a bit. We're struggling with how to do that interplay to help the user decide, is it this drug or that drug? For now, we're at a single drug tool. HLA and other genetic data, which you'll probably hear about today, I think. We are starting to try and incorporate that into the RECAM. Herbal and dietary supplements are always a challenge. Not many of them are in liver tox, so that domain is problematic. Global applicability. There's some emerging data from Asia that we may need to adjust in places where Hep B is prevalent and endemic, because the scoring we have is not quite right for them. And then lastly, being at the FDA, I want to emphasize one thing, that use in clinical trials. RECAM nor RUCAM are not to be used in clinical trials. Neither one was developed upon or validated for clinical trial data. And there's a whole host of reasons why neither one fits very well for clinical trial data. That is still going to have to be done by expert opinion. And with that, I will end with the acknowledgments for all the people who worked on this project for a few years, particularly Maribel Lucina, who was my co-author, co-first author, and had just really terrific insights into building that tool, and a lot of the things I talked about were her ideas. And that's it. Thank you very much for having me speak today, and I'll stick around for questions. Thanks. Bye.
So I'm Paul Watkins. I'm going to be talking about the use of genetic risk scores in the diagnosis of DILI. And I'll start with a true case report of a 76-year-old man who developed pneumonia, was treated with amoxiclav and azithromycin, and then was noted to be jaundiced 3 weeks later. He became quite ill and was hospitalized. You can see that he had a 10-pound weight loss, also was brightly jaundiced with a bilirubin of 15.5 milligrams per deciliter, a significant fall in his albumin, and his R value was always less than 2.0, indicating this was a cholestatic injury. His laboratories did normalize over a month, but it took 2 more months until he felt entirely well. He did not recall ever taking azithromycin or amoxiclav prior to this event, and a workup for other causes was negative. And the question is, was the cause of this man's significant liver injury amoxiclav or azithromycin? And I will be talking briefly about the sequential steps we believe are necessary to lead to idiosyncratic DILI. Some recent studies we've done together with our European collaborators on the genetic basis for susceptibility to amoxiclav DILI. Then the emerging role of genetic testing and causality assessment, and some conclusions. So we now know that most idiosyncratic DILI actually results from an adaptive immune attack on the liver. That is a cytotoxic T-cell mediated attack. But there are sequential steps between drug exposure that must occur prior to having a position for this adaptive immune attack. And that's been best illustrated in this diagram put together by Jack Utrick. And it starts with you need to have a neoantigen, and there are a number of ways that can occur. You need to have liver inflammation and release of the neoantigens from the hepatocyte believed to occur in exosomes to then be picked up by professional antigen presenting cells, which can then present that antigen along with co-stimulatory molecules to the right T cell, that is the T cell that has the right T cell receptor, leading to activation and expansion of clones of T cells, which can then hone back to the liver and mediate liver injury. And we know from prior studies that genetic studies, that there's a HLA risk factor associated significantly with risk for AC DILI, and it's a class 2 molecule 1501, which presumably is the major molecule on professional antigen presenting cells that present the antigen to activate T cells. In addition, there is a class 1 HLA molecule 0201, which is presumably involved in presenting the neoantigen on the surface of hepatocytes to react with the activated T cells and cause the injury. We also know that there's a separate genetic risk factor, a non-synonymous variant in a gene called PTPN22, which is involved in T cell activation and is strongly associated with risk for AC DILI. Once you take into account these risk factors, however, in a large discovery cohort of 444 patients who have experienced DILI due to amoxiclav, there are no significant SNPs in a GWAS analysis. And so we took a different approach in this manuscript that was recently published in Gastroenterology, where we used that 444 discovery cohort, but also a parallel 140 case validation cohort. And what we did was a procedure called TWAS, or transcriptome-wide association, and that's using the GWAS data to predict the expression of genes in specific tissues, in this case, the liver. And they're public databases, GTEx, that allow you to do this. And this reduces the number of variables from about 6 million SNPs in a GWAS analysis to the predicted expression of around 20,000 genes, which significantly lowers the level of significance for significant differences between cases and controls. Also, we know that regulatory variants largely underlie susceptibility. And in fact, there was a study of 200 cases of AC-DILI with exome sequencing that was unrevealing. And when we convert the GWAS data to the predicted expression, looking at the predicted differences in predicted expression between cases and controls, we do find there's a single gene which passes the threshold of significance, and this gene is ERAP2. ERAP2 is one of two genes, the other being ERAP1, that are located in the endoplasmic reticulum, and after PEP proteins are digested, normal cellular proteins in the proteasome to create peptides, they enter the endoplasmic reticulum, where in general they are too big to fit into the peptide binding site of class 1 MHC molecules. And ERAP1 and ERAP2 then trim the peptides, each with different substrate specificity, two peptides that are appropriate size to fit into the class 1 MHC molecules prior to their trafficking to the surface, where you can, it's part of the self versus non-self immune recognition pathway. In the case of ERAP2, there are two basically haplotypes. HAP-A, which has been associated with the risk of certain autoimmune diseases, but it was HAP-B that was associated with the risk for AC-DILI, and this produces a truncated messenger RNA that's rapidly degraded. Again, not associated with autoimmune diseases, but associated with the risk of AC-DILI. So what we believe is occurring is that this reduced, greatly reduced activity of HAP-B shifts over peptide processing to ERAP1, so that in ways we don't understand, treatment with AC leads to generation of peptides that are processed predominantly by ERAP1 to then fit into the class 1 HLA risk allele, which in the case of AC-DILI is predominantly the O201 prior to its trafficking to the cell surface. So what we have, as we know, is the class 2 HLA risk allele, the major class 1 HLA risk allele, the variant in PTPN22. We also identified a second class 1 HLA that was rare in this same publication that was associated with risk. But importantly, this association with ERAP2 gets us into the hepatocyte antigen presenting part of this entire scheme. And one of the things we pointed out, which may be obvious, is the importance of zygosity. So for instance, with the major class 1 HLA allele, your odds ratio or risk is doubled if you're homozygous versus heterozygous. This was also true for the class 2 1501, but interestingly was not true for ERAP2, and we have some additional observations that support this fact that it's homozygosity that is the important thing. And what I'm showing you here is the discovery and validation cohort results. So taking these now 5 independent risk factors for AC-DILI, it has been possible to create a genetic risk score, which is shown here. It's basically a multiple regression that has whether you have 1 or 2 alleles, homozygous or heterozygous, et cetera. And in the manuscript, we give a couple of examples of how you can calculate the risk score based on how many of the risk alleles an individual has. In order to really make this most useful, however, you need to ask the question, what is the incidence of AC-DILI in an average patient? And fortunately, from Iceland, Einar Bjornsson has published the experience there where they have more complete records and can get a more accurate estimate of what the chances are of a patient developing at least clinically recognized DILI after a course of AC. And that was estimated to be about 1 in 2,350. Interestingly, that's very close to the mean estimate that Ayako Suzuki came up with examining the Veterans Administration database. So when we put that into this table, where on the left we've put the genetic risk score ranges in 10 different quantiles, again with both the discovery and validation cohort results, we can then predict the incidence of DILI, clinically recognized DILI, from someone having a course of AC. And if they have very few risk factors, that'd be 1 in 5,500 roughly, or 1 in 6,700. But if they have all the risk factors, we're moving into the 1 in 100 range. So we're able to really splay out the risk of individuals. And this risk, a genetic risk score, is very specific for AC DILI, highly significant, not significant for flucloxacillin, for instance, where we have a substantial number of cases. In fact, the trend is in the opposite direction, actually to be protective. Amoxicillin alone does not share this combination of risk factors. And actually, the only other one is cefazolin, you can see here. But again, the trend is in the opposite direction. And this p-value does not survive multiple comparisons. So one of the ways that we diagnose DILI is to incorporate, and this is really expert opinion, the characteristic features or clinical presentation or signature. And that's a wonderful thing about this LiverTox website, is they give us those classic presentations. And as we heard from Dr. Suzuki, there are classic presentation clinical characteristics, generally elderly men. There's a characteristic latency. It also, the injury tends to be cholestatic or mixed relative to hepatocellular. So if you put all these into a multiple regression, comparing AC DILI to DILI from other causes in the Dillon network, you can see that the genetic risk score is the most predictive, both in terms of odds ratio, but also p-value. So it's definitely significantly adding in causality assessment. So to finish up, to go back to our case, his genetic risk score was 2.7. So where does this fit in our quantiles? He would be in the 6th quantile, suggesting his risk is 1 in 572 or 1 in 395 in our validation control. That's very much higher risk than would be for zithromycin. We don't have a genetic risk score, but it's going to be in the 1 to 10 to 20,000 range. So with this information, we were quite confident in saying that this individual's liver injury was due to AC and not azithromycin. So the final take-home point is that combining genetic testing with clinical risk factors should improve causality assessment and is likely to have a role in risk management going forward. And just to close, this is the last time we got together for a picture in the U.S. Drug-Induced Liver Injury Network. Piola Nicoletti, shown on the right, is the major geneticist who actually did the work that I talked about. And all this has only been possible because of our close collaboration with our European colleagues. So thank you very much.
Okay, first question is to Ayako, if you can come. We will ask questions both from the Q&A section as well as my own. So Ayako, you showed the findings in your database search. Once person who is exposed to a hepatotoxic or drug with potential to cause DILI, and what the prevalence of individual conditions were in that cohort. So this is probably, in my mind, is a base rate you can get to start using a probability of pre-test and then post-test diagnosis. So if you follow that, your incidence of autoimmune hepatitis in the biggest cohort of people who have been exposed to coamoxiclav was 0.015%, which means that I would say that no test will make it higher probability. So do we need to expect all these patients to be tested by the profile, which we ask for a causality assessment, autoantibodies, immunoglobulins? If you put that pre-test probability, it's very unlikely that you will pick up the diagnosis. So exhaustive tests are really avoided.
Yeah. So the Guru, what I learned from that the EHR data is that the probability is really influenced by the patient, the status and the condition. So I think we needed to develop some sort of algorithm, and then the combining, genetic risk score, and also we haven't learned yet, but the other clinical conditions, the comorbidity and so forth. We needed to consider those aspects and then eventually develop risk the prediction model. That's my thought. At this point, this single data probably not allow us to generate a practical algorithm yet.
Okay.
What do you think? I want to hear about your thought as well.
I think, I mean, basically, you have a conflict of getting a perfect diagnosis as well as making it practical. So I will actually ask Skip, whose presentation would actually challenge the concept that you are developing. In other words, if you have got a base rate, which is 0.015, and your highest base rate for drug-induced liver injury is about 35% or something, if I remember. So you should really not expect someone to do all the tests so that they can score high on the RECAM. So Skip, some of the design of the RECAM will stop people even trying this tool as soon as they get some of the tests positive. So do you feel that it will allow the base rate for an individual to be considered when you come up with an answer, or is it too far off?
So I'm just trying to understand what you're saying, Guru. You're saying that the base rate or background rate of whatever your beginning of your question was autoimmune hepatitis.
Yes.
And the base autoimmune hepatitis is actually, when you look at it clinically, it's actually more common than DILI overall. If you're looking at overall DILI, if that's what you're getting at. So what you're saying is that in order to overcome that, you may not, the autoimmune marker testing will become paramount because that's the more likely pretest probability. Is that what you're getting at? Did I say that?
Yeah. I mean, in fact, if you take different contexts, if you take jaundice, actually autoimmune hepatitis is much lower frequency than drug-induced liver injury. Same way, if you already have another preconditioning, like somebody who is already exposed to a drug, which you find out, and this drug is known to cause DILI, pretest probability of autoimmune hepatitis goes down. So would it be practical for people to expect to do all the tests we need to complete the causality assessment?
No, I see what you're saying. Okay, I see what you're saying. So yeah, it gets to the point of who's going to use the RECAM and what do they know clinically ahead of time. So that's a very big challenge, right? That's a very good question. Like for a hepatologist, in fact, RECAM, as you know, a lot of times hepatologists don't use RECAM, right? Because they know about these clinical pictures, so they're already forming a pretest probability of what they think is going to happen. And yeah, that's right. If you've got a perfect picture for autoimmune hepatitis, do all the other tests become less and less important? My answer to that, as far as the RUCAM or RECAM, is that it's a broad tool. It's to be used by a lot of different people, even non-hepatologists who, for hepatologists, we might say that's not even close to DILI. Don't even go use tools. So that I think that's the challenge you're getting at, to me, is what you're saying. It's a different pretest probability of the person walking in the door to use this test. And that is a huge challenge. And so what we've done is made it a general model, let's strip down CAR without any, that anyone can use. And it won't be good enough for hepatologists. I think that's what I'm hearing. Is that about right?
Yeah. So what's the next step for RECAM?
Oh, I think the number one was the top of my list is reliability. So, just to let you know that in the DILI, we had to rebuild the whole thing on a computer because it's a HIPAA thing. We have to be able to store the data, and the website does not do that because it doesn't want to. It's a HIPAA issue. So we had to rebuild it, and then we're going to do reliability studies with it. 2 different persons, same person, score it and see and make sure that it is reliable. That's number one. And then we're actually putting in genetic data as number 2, which Paul was talking about.
Okay, well, then I'll ask Paul. Paul, how many people or what systems are there for this test to be asked and results to be got, and how quickly they can be done? You might have seen there is a randomized controlled trial of preemptive pharmacogenomics, which delivered a test in a week's time of prescription so that they could modify their prescription. So how far are we, let's say in USA, to get such a facility?
Yeah, well, the strongest risk associations that have been identified are with HLA, risk alleles. And that's available, that genotyping, usually actually HLA sequencing, is part of any organ transplant program. So any academic center is able to get in short order HLA identification, and they're the strongest risk factors. And there are a variety of drugs now, list is lengthening, that have strong associations or significant associations. Now, in terms of PTPN22, ERAP2, there are no commercial outlets for that. And I think, for instance, the genetic risk score for AC DILI, I bet will be employed first in clinical trials where there's a liver event and the patient was receiving AC, and the question is, was it the study drug or was it confounded by the antibiotic? And obviously, drug companies can get this kind of information easily. I think we'll have to get significantly more predictive in order to really use it in, preemptive genotyping prior to treating individuals, at least with most common drugs, the antibiotics. It may be that knowing 1 in 500 would be useful if there's an assortment of potential treatments for serious diseases. But I think we need to just sharpen our predictiveness by getting additional risk factors and continuing the studies we're doing.
Going to Nelia, you mentioned the combination method of causality assessment for HILI. You highlighted APASL guidelines for it, and it had biomarkers as a box. And were there any biomarker which you can highlight which might be helpful in this scenario? And also the question on genetics. I mean, you probably know that at least 2 herbs, polygonum as well as green tea, have been associated with the same HLA genotype in terms of liver injury. So can you consider those as a biomarker? And is there any other biomarkers which have been used in this assessment, or what biomarkers they were implying when they had this in their method?
It's true, there are some biomarkers, there are some studies from genetic tests, mainly in herbal tea and green tea, but there are no one that I can say that is the most important or identified as specific for that. There are many biomarkers in herbal, such like in drugs, but I don't find one to say that is specifically the same for genetic test.
Yeah, this is like evidence chains method of, there was a box on that. Did they give an example of the biomarkers in there? No. None.
Yes, there are. There are many biomarkers that are, but I didn't mention them because they are not specifically and not used in every site.
Okay. Few things coming online. One is that any of this causality assessment can differentiate drug-induced liver injury from ischemic hepatitis? Is there any factors in the causality assessment methods which you could identify? And Ayako, did you have any criteria to identify ischemic hepatitis other than the codes?
You mean as a part of exclusion?
Yes. Yes.
Yeah. The shown in a slide, ischemic hepatitis is about the 10%, including the shock. So the 10% of about 6% of acute liver injury following amoxicillin clavulanate actually, ischemic hepatitis.
Did you use just the code already or the diagnosis?
Right.
Mm-hmm. Yeah. So can I just ask you, in patient, there are studies to show that only 10% of drug-induced liver injury or events which are related drugs are identified. It comes from a study from Europe. So did you see whether there was a disparity between DILI as identified or acute liver injury, which you identified, which had no other etiology, which wasn't coded as DILI? If so, what percentage were missed?
So the Guru, this is this study was done in ICD-9 code era. So there is no code for drug-induced liver injury.
Okay.
Right. So we did not use ICD-9 code to define drug-induced liver injury. This framework using structured data, the laboratory data, and the diagnostic code, and combination of them to come up with this algorithm. So we cannot compare the physician's diagnosis and our diagnosis. I think in an era of ICD-10 code, probably we could do that kind of approach. But I think in reality, those the concordance are the case between physician's diagnosis and our identify the case probably very low, because we reviewed about 18% of the cases, and I realized most of the cases actually are possible but indeterminate after we exclude unlikely cases. So in real world, a lot of cases are not properly, completely evaluated to make a diagnosis of drug-induced liver injury. That's what I learned from our analysis.
And when coming to the practicalities of it, you could really set up an alarm system, right? I think this is what was proposed. That the paper I was mentioning comes from Thierry Poinard's group, nearly 10 years ago, where he set out an alarm in their lab results section, and a trigger saying, well, okay, this could be DILI, and then you go and evaluate, and then it can be combined with the RECAM.
Right.
Then you have got really almost like an identification system for drug-induced liver injury, which involves expertise as well as the automation.
I think that's the thing we need to do next, because we learned retrospective data set. Yes, we could capture overall the view, but I think we needed to have a prospective study to better understand. Yeah.
Coming to Paul, standard polygenic scores really include tens of thousands of genetic signals, which don't get picked up by genome-wide association study because the bioinformatics and statistical rigor means that they'll all be selected to identify absolutely true positives and exclude any doubtful false positives. So they have kind of lowered the threshold. Different techniques are used to lower the threshold and then incorporate their element of contribution to DILI. So why is it not possible for us to do that for DILI?
Yeah. So what you're saying is when you have the Manhattan plot, normally it's 10 to the -8 significant. You can continue to lower that and get hundreds and thousands of genes where expression is different depending on your level of significance and create what's called a polygenic risk score.
Yes.
We took a different approach, sort of stepwise, in our genetic risk score. The key then is you have to have validation cohorts because statistically you're on shaky ground the farther you lower that level of significance. But actually, this is something that Paula Nicoletti has been doing and comparing the polygenic risk score for DILI, sort of all-cause DILI, individual cause DILI, dividing it phenotypically with other liver diseases, for instance, and finding some interesting associations. And it may be, and of course, there was the Takabe paper that came out in Nature Medicine, where he also did this for cholestatic DILI and said it distinguished DILI from non-DILI in a Takeda clinical trial. But it's very hard to get stuff like that published with the small numbers of cases that we're forced to have with drug-induced liver injury. Mm-hmm. It becomes statistically shakier and shakier the farther down you lower that significance. But it's an active area of investigation.
Okay, thank you. And Paul, are you saying that you will be taking genetics up next as soon as you had a bit more reliability answered, and that will be incorporated? And how will you weight these tests? What methodology you will use to give the weightage for the genetic tests?
Yeah, that's a good question. So we're probably going to set forth an initial idea of how many points to give, and then we will somewhat similar to what was done with the green tea HLA associations. We will see, did it help or improve or better match our expert opinion scores? In other words, does the HLA typing really help in retrospectively when you look at our cases of DILI? So it gets to the question of sort of a chicken and egg, and whether or not, if that's in Paul's case, which he had, his HLA data actually swayed the expert opinion to go the other way. So it is a challenge, and we're going to probably initially look at how well or how it doesn't help with expert opinion. And then we'll probably dive into the cases and see if, in fact, like with Paul's Watkins case was brought up, when he actually we dove into that case, it did appear that the HLA probably swayed the expert opinion in a way that was justifiable. So that's a long way around it, but we're basically putting forth some scores, see how it performs, and then dive into the cases.
Thank you.
Sure.
I have got one question in the box here to ask. Can anyone tell what is the best method to tell when there is a polymedication, one drug over other? So is there anything in the Nelia's box for us to choose? You vividly showed that even within the drug-induced liver injury, you can't, herbs, you can't tell one from the other component. So how do you tell?
Yes, polymedication is very frequent with herbs. And this is a big problem, It's not easy to know which is the real culprit. In general practice, we try to apply the scale for each of these medication and try to see which is the more probable. That's not easy, and I hope that genetic tests could help us, as Dr. Watkins showed us.
Excellent.
Yeah, for the medications, not for the herbals, but I would just say to the clinician, the things that aren't in the RECAM or RUCAM so much is the signature for that particular drug, the timing that's very stereotypic for a particular drug, or the R value or whatever. That is what I think is what we have to incorporate into the RECAM to choose one drug over another, besides just the timing. It's that signature, and that's what the clinician needs to know about. Thanks.
Thank you very much. Ayako, go on.
Sorry, related to that, the causality assessment in the polypharmacy case, I think if we could incorporate more like the drug information, that might be helpful, because the drug hepatotoxicity is not just causality, but also incidence as well as severity. Not all drug causing acute liver failure. So if we can incorporate that kind of information in Dr. Hayashi's, the scoring system, I think that might be helpful. In addition to the signature pattern. Sorry.
I think it's much more robust and I would say correct way of really almost creating a pretest probability of the drug being the cause, as well as individual diagnosis being the almost like prioritizing the diagnosis. Yeah. So that is the starting point, is what you were setting up at the moment, right?
Mm-hmm. Yeah.
Yes. Excellent. I think we are absolutely on time. I'm enormously grateful for Paul, Skip, Nelia, and Ayako for having taken time to prepare and present. And I hope lots of people running around the world have been able to benefit from it. And this is recorded, so it'll be available for people who are still passing through their midnights for tomorrow morning to watch. So thank you very much. And thanks for World Gastroenterology Organization for having spent their energy organizing this. Thank you.
Thank you.
Thank you. Thanks for having us.
Bye-bye.
Bye-bye.
Bye-bye.